Should we continue for question and answer session or should we stop here? Do you have any question? Yes.
Assalamu alaikum. I have a question from the endocrinologist, Dr. Fahim. If the HbA1c has found to be normal, like below 5.7 or 6, so do we have to check for resistance, insulin resistance, still in patients with MASH?
Is less than normal range, within normal range 5.6 and less than that. There are no guideline recommendation that you should look for the insulin resistance. So कोई ऐसी recommendation नहीं है where we ask a clinical physician या कोई भी guideline जो आपको कहे कि आपका एक MSLD का patient है या dyslipidemic patient है या even obese patient है and you need to check insulin resistance in them. So ऐसी कोई guidelines है नहीं where we should not be doing it. ठीक है?
I'm sorry, I will just respond this. When it comes to normal A1C, it's not for the diabetes when we are looking for insulin resistance, it is with the insulin resistance is felt is the primary event which leads to obesity, mast cell, diabetes and all CKM. So the Basel guideline do suggest to screen these patients who are having fatty liver for insulin resistance because that is one of the diagnostic criteria, and it's particularly in the patients with the lean NASH, it is a very important criteria to pick up insulin resistance early stage in these patients. So the Basel do say AASLD guideline, EASL guideline does not include insulin resistance as a diagnostic criteria, but they do say the insulin resistance is there as a risk factor.
So we should check for fasting insulin?
Yeah, not in our part of the guidelines.
Okay.
We talk about ADA, ACE and IDF guidelines, so then maybe the liver, yeah. If you want to check, that should be done fasting insulin level and fasting blood sugar level, and the HOMA-IR score, HOMA-IR calculators are available, so you can just put in the numbers and they will give you that the patient has insulin resistance or not. So maybe for ASLD guidelines, they recommend, not for the obesity or something else. Thank you.
Another question from Dr. Bilal about the duration of resmetirom. One of my patient has been in resmetirom and he just asked at every follow-up then when should I stop this?
So there is no, excellent, there is no, I think it's like considered a chronic condition, and so right now, there is no guidelines, it's up to the individual. Patient, I've been continuing it. That's why the study is still ongoing. So after the 5-year data will come out, what will be the long-term outcomes? The only group of patients, so if their patient is tolerating having, positive, so the group of patient I'm stopping it if patient has worsening or progression of fibrosis or having some. I had few patients with drug-induced liver injury and thyroid issue. Those are the only patient I'm stopping. We do talk about it. Just like diabetic and antihypertensive medication, this is considered just the cost has been issue. In the US, we have seen that there is a patients who are from stage 2 and they got stage 1 and the insurance stopped covering them because now they have improvement and that was on the medication. So right now, I think that I would continue it depending on what the stage of fibrosis, but I'll just follow the fibrosis and other things right now.
And if it comes at the stage 1, like F1, and the ALT is also normalizing, still we have to
I think you have to talk to the patient because that's what you did with the
Yes.
medication, right? So I had few patients who had lost weight and have on GLP-1 started at the same time. Those are the patients I have stopped it. Okay.
Okay, and follow FibroScan yearly?
Yeah, so I do it every 6 months,
6 months.
early on, but
Okay.
yearly is the minimum that,
Okay.
the guideline says yearly. So in Pakistan, I would do at least yearly.
Yeah,
Okay,
thank you.
Dr. Gyas? Okay, so one more. Sir, you mentioned in your presentation that we can use resmetirom in cirrhotics as well.
So I think that is not, because there is data that was present in ASLD, the company has been doing many different trials. So there is an ongoing MASH compensated cirrhosis
Yes.
trial that has been going on. The data will kind of come next year. But early on when they enrolled patient in another NASH trial, they included patient with cirrhosis. And their data has shown not only safe it is, but also at improvement. I had few patients which, early on in the FibroScan thought is stage higher fibrosis, But then they had like more cirrhosis, more fibrosis and cirrhosis. I continued those medication. The main thing is the safety, right?
Yes.
And it's safe. We have been using it in my clinical trial, which I'm doing like with Madrigal. I have 7 patients and I haven't seen anything like that. Secondly, what would be the response of it, right? The group of patients like, portal hypertension, if they have varices or other thing like, advanced clinically significant, I'm not using in that one. So there is a patients who have early on. If you wanted to, you can use it. In America, insurance doesn't pay for it, but if you have availability, because there's nothing else to offer, right? What will gonna happen? Like transplant the transplant is too. Most of these patients are like 65, 70, so you would, and it will gonna get ahead an approval for, cirrhosis in the next couple of years. So I would, in Pakistan, if you have availability, I don't know what our other experts feel, but that I would feel that you can consider it.
Okay, can we use this combination of resmetirom plus semaglutide?
Even if you look at most of the clinical trial, even the resmetirom clinical trial, about 15% patient was already on GLP-1. And if you talk to our endocrine colleague, there are a group of patients diabetic, they don't lose any weight or other things. So it has been allowed, it's been a combination. But if you have a new patient of stage, higher fibrosis, I would not recommend, if you're using for liver specific, I would not start it together. We had patients, so you start one, wait for 6 months or a year and see 6 months is the minimum. And then if you want to add on, that would be added. In the future, just like diabetes, high blood pressure, it's a combination treatment with different mechanism of action will be the backbone of the treatment that we will be using.
So which drug first, semaglutide or resmetirom?
Depending on if someone has diabetes and obesity, I would just use semaglutide for sure. There is no question. If they don't have any risk factors, then or lean muscle D, if you have it stage 2, those are the group of patients you would use resmetirom. So I think it's all individualized, right? It just.
Dr. Gyas, would you like to?
Yeah, but for F4 fibrosis, I think resmetirom, I shall say that one has to be very, very careful.
Yes, it is hepatic.
There's a serious risk of decompensation. So in trial setting, maybe, Dr. Bilal, if I've understood correctly, that he's using it in 7 of his patients in advanced fibrosis, but I shall like to exercise heavy caution in this setting. In F4 fibrosis, unless I'm in a trial setting, it's preferable not to use resmetirom. F3 is fine, but F4 definitely one has to be very, very careful.
So continue this same. So in clinical practice, it is very difficult to differentiate between F3 and F4. So what do you say?
It's not just the transient elastography where its sensitivity, specificity is something to the tune of 71, 72%. One is to combine FIB4 with transient elastography, combination of the two. And if the albumin is less than 3, again, just a single factor, albumin less than 3, platelet count less than 90,000, one has to be careful then.
So, Dr. Bilal, would you like to add?
I think, we can have a discussion for 1 hour. I think with the time we have to be like, so clinically significant portal hypertension is something you have to be very cautious, as Dr. Hayas has mentioned. But there are many patients who are, as I mentioned, that we have it. So I think that you can use these markers very easily, and then you can, pay attention to that.
Okay. So is there any question?
Sir, I have one question. If the patient already has some thyroid abnormality, in that particular case, along with especially hypothyroidism is associated with metabolic dysfunction. So in that particular case, what is the is the indication remains same for resmetirom?
Dr. Bilal? So very good question.
Yeah, as long as if the patient is already on the treatment with thyroid, you can use it, right? It's just about the untreated or sometimes that these patients had never been had in it, their thyroid levels can change.
Sir,
so
if we found simultaneously both the things like F2 fibrosis along with thyroid disorder in one setting or newly diagnosed both the things simultaneously, so we need to cover first thyroid disorder
yes,
first?
Absolutely.
Definitely.
There is no question about, first thyroid and then, it's a chronic condition, you can wait, right? And so that's why, so you treat the thyroid first.
And sir, what about if we talk about the side effects, if the patient report dizziness with resmetirom, in that particular condition, what is the
Again, I think
recommendation?
that if you look at the side effect, it wasn't different dizziness and all these as compared to placebo. There may be something else is going on. But if they are, you don't know. It's still in the real world setting we are. But these are well tolerated. I have 100 patients on it. So there's not that. But if you feel like if it, just stop it and then see whether the symptoms goes away. This is not like a life and death kind of a thing. If you doesn't like it, you stop it, try to see what the symptoms are.
Especially if the occupation is driver, if the patient is driver, has occupation.
Sorry,
driver.
I didn't know.
If the occupation patient is driver of long
Again,
routes.
so don't use it. Yeah. It's not. Use the GLP-1.
Because
Dr.
in
Bilal?
states and British, in the British part, there is basically guidelines for from the National Highway Authority in the medical practices
Yes.
as well. Because we don't have right now any
Yeah,
such
again, I think
guideline
it's
there.
a very individualized decision making that comes in, right? If the patient is having any of these, we have these medications which we don't hear from any side effect. But if patient side effects, the easier thing is stop it, see whether the symptoms goes away. But if symptoms persist, then they need to do other medical tests to figure out what's going on. Okay.
Thank you, sir.
Bilal, in your talk, and Dr. Amna, in your talk, you said that 3 to 4 cups of coffee should be taken every day. Do you have to space it, or you can take them together? Say, if the first cup of coffee should be at 10:30, 11 in the morning, or one can take it all together, or it's 11:30.
The first cup should be at 11:27. I don't think so. There's any studies that have done. It just these are retrospective studies that shows the black coffee has shown. So it doesn't. I don't think so. The time is it, and any matter into it.
Thank you for this wonderful discussion. Now I will request.
Akram, just a comment. So when the COVID vaccine जब आ रही थी तो किसी ने पूछा कि which vaccine is the best one? तो किसी अक्लमंद ने जवाब दिया जो मिल जाए. जब कॉफी मिल जाए.
We need it right now.
Okay, so I will request the panelists to conclude the session.
Thank you very much. Wonderful session. In the interest of time, I would say thank you to all the speakers and to the audience for their active participation. Just one word of caution with the recent evidence that Bilal has shown, vitamin E, 200 international units. So if you are using it in muscle, the dose, equivalent dose for synthetic vitamin E that is available in Pakistan is 90 milligram. We don't even have a capsule for that. So be careful, don't use higher doses, use lesser doses. You have to multiply it with a factor of 0.45 to convert international units into milligram. So with this word, thank you very much, everyone, and I think we all need a cup of coffee.
Okay, thank you, sir. Thank you very much. Now it's time for tea. So we will be back after 15 minutes.